Thank you for inviting me to present in this conference. Thanks organizers, Wendy Sperman and Karin and Lara for giving me this opportunity to present in this important conference. I'm from Sudan, from Khartoum, while the White Nile and the Blue Nile meet each other and forming the Great Nile. I'm from the old civilization, Kosh civilization. These are pyramids in the north part of our country. And I'm working on this hospital. This hospital is built by the Japanese in 1985. And this our newly established 10 years ago or 15 years ago emergency bleeding center, dedicated emergency bleeding center, where our WGO Khartoum Training Center is functioning. So talking about Nuffield is a rapidly growing health challenge and is affecting about 2 billion people globally. The highest prevalence is the Middle East and South America and in Africa. The pooled prevalence of Nuffield mostly done based on ultrasound and globally estimated like 25%. With some geographical variation across the world. The highest prevalence rate be reported in the Middle East and the American countries, around 30%. There is limited data in Africa, in some countries, and reported the prevalence around 13%. Strikingly, in Middle East, in country Amman, there is a very high prevalence. Could be genetically related or something, but it's reported in this country. High prevalence and high increasing incidence of Nuffield. When giving me this task to present the model of care of NASH, of Nuffield, I went through the literature, and the most comprehensive maybe finding I found through EASL Foundation in the group of where is they supported group of 33 leading clinician researchers and patients advocates groups from across Europe and North America, and they drive this consensus. Really, I found this consensus is and the step of the model of care for Nuffield is good. Why I stick to this 8 recommendations from this group. The aim is improving the model of care, and the key challenges what service should be delivered and where service should be delivered, who should deliver which service, and how the service should be integrated. So these all 8 recommendations are answering these challenges and questions. So recommendation 1 was the patient control pathway for Nuffield and NASH. So this recommendation is talking about who should be screened, a risk stratification, diabetic patients and patients with cardiovascular disease, defining the tools and the guideline for screening, how these people should be screened, especially in the primary healthcare setting. You need these tools and guidelines. And very important, they mentioned the discussion with the patients. So patients should be actively involved in the management pathway, and the options for the management should be well discussed with the patients. The recommendations 2 is the guidelines on screening and testing. So this recommendation talking about the non-invasive markers, the importance of non-invasive marker, like should be easy used, especially in the primary healthcare setting, like FIP4 and elastography maybe is a secondary level, and in African setting maybe like ABRI-4. Also, fibroscan can be used in the tertiary level or secondary level, and fortunately enough, in many African countries, they starting in the tertiary level using the fibroscan. It's available in Ethiopia. I visited the center there. In Sudan, in my center, the fibroscan is available. So the should be calculated score symbol for simply calculators based web-based or automated symbol scores, and the practitioner, general practitioners and GP should be trained in interpretations of these scores, and should be trained and aware of about what the next step when you need diagnosis of these patients. So you need the education awareness among practitioners and general GPs. So the recommendation 3, the guidelines on treatment strategies. So a lot of data about the treatment with novel and effective treatment, many studies. There's a lot of talk about efficacy of vitamin E and pioglitazone. Also new anti-diabetic agents like GLP, IRA, and SGLT2 inhibitors in diabetes. They prove to be effective. I have good effect in NASH therapy, and as well they have good effect in the cardiovascular and kidneys. So they are preferred and used, and there's many studies about their efficacy in NASH. So also, but most of the therapies in treating NASH concentrating in targeting this 4 pathway. Most of the treatments and drugs are targeting this 4 pathway. The first pathway is a fat drugs affecting or working on fat accumulation, reducing fat accumulation. Antioxidant, oxidative effect, inflammation, and apoptosis, this pathway 2. And these drugs acting in the intestinal microbiome and endotoxemia. And lastly, drug acting in hepatic fibrosis. There is a lot of drugs in this market, but this absence of approved evidence-based pharmacological therapy in management of patients with NAFLD and NASH. The mainstay will be in working on comorbidities, metabolic syndrome, and diabetes mellitus, and cardiovascular problem, and managing them. Lifestyle modification and management of comorbidities, as I mentioned. There is a good meta-analysis published of 7 studies encouraging coffee intake, saying that taking more than 3 cups of black coffee observe that lower risk of NAFLD, and this top level of evidence. There's many mobile applications, is Android-based or iOS-based, like the N-Body application, which is published recently randomized control study showing the benefit of using such app in management of patients with NAFLD. Recommendation 4 is the prevention program. The prevention program is concentrated to those type of patients who are not NAFLD or not NASH, but who have risk factors. These mostly patients who can benefit from early intervention. And those patients, like patients with type 2 diabetes or metabolic risk factors, this should be in these recommendations, the addressing that should be good collaboration with the GP, primary health care, and hepatologists. There's good collaboration to make good patient management. The recommendation 5 emphasize on the role of primary, secondary, and tertiary care providers in the management of patients with NAFLD and NASH. So first, we should do the risk stratification. The patients with low risk can be treated in the primary care with the GP. The high risk should be treated in secondary or tertiary level. There should be awareness among other specialties like endocrinologists and cardiologists, because those are seeing the patient with these comorbidities, and you can early detecting the patient and potential NAFLD patients and prevent by giving advices. The recommendation 6 is around co-locating NAFLD NICE services with the services for the treatment of common comorbidities. And this we are talking about the multidisciplinary approach. There is many around the world with combined clinic. There is experience in UK, in Israel of combined such combined clinic. Is feasible in big multi-specialty hospital. In all urban areas and remote areas, it's difficult, but you can use connections with other centers using telemedicine. And also you can, this could be also, the approach would be, could be to this specialized clinic like diabetes centers, detecting patients or potential NAFLD patients. Recommendation 7 is the structure of the multidisciplinary team responsible for the management of patients with NAFLD. And this, the team should have hepatologist, dietitian or nutritionist, physiologist, and cardiovascular specialist or diabetologist. So specialist nurse is very important and potential for navigating patients and driving patient care. And in gastroenterology, you have such experience in hepatology, in patients with hepatitis, stomach nurse, and IBD nurse is a good experience. We can learn from this. The final recommendation 8, is a coordination and integration. So this very important, but it have some challenges, special insurance system and integration of the insurance system. Maybe this is not a problem in developed countries because they have good data and data integration system, but this is the major challenge in our African countries where there's a problem of health information system are lacking information, especially in our regions. So this should be, we should concentrate in finding patients and linking them to the point of care. Also, we should consider this because it's a different health service level, as I said, and this integration should be tailored accordingly, and we can learn from also other experience of like HIP programs and success in African countries and integration programs and health information system built in these programs, so you can learn from them. Coordination in different levels of service delivery, primary healthcare, between relevant specializations also. And also we have the COVID experience, we can learn from it also different type of communication and consultation, software based on Zoom and Meet, and also echo clinics, which connecting many physicians. This can be used for such coordination. Talking about the African, we'll finish talking about the African perspective in management of NAFLD patients. And we noticed that the increase of incidence of NAFLD and NASH in many African countries. There is published data about the increasing of NAFLD and NASH, although the prevalence is low, but it is increasing in some regions and countries. And we start to see cirrhotic patients without underlying cause. Mostly, some of them are suggesting that the underlying cause could be NASH. We see HCC patients also, and we see transplanted patients. In Sudan, we have more than 100 transplanted patients who did transplantation abroad. We see some of them, the underlying cause of liver transplantation was NASH. Of course, there's many challenges and causes of driving or seeing many new patients or increasing the prevalence of of NAFL in our countries, like westernization of diet, change of lifestyle in Africa. Uh, Definitely, we have a very weak primary health care in many African countries, and we should work on this because strengthening the primary health care will be the key of success in NASH. We need the local guidelines to develop our local guidelines, which could be tailored to our conditions, to our area. We should have our local guidelines. We thank some of the World Gastroenterology organizations. They have a good um, guidelines concentrating, looking for these countries, African countries and poor countries, and they're in guidelines concentrating in the management of these patients in this area. So there's a very good NAFL guidelines done by WHO. So you should promote ultrasound training in remote areas, train GPs and medical assistants in this area because they can detect early this entity of disease. And of course, advocacy in the school learning our children's and youth about this increasing problem of NAFL and NASH and how to prevent this. Uh, Reach diet, and national diet, natural diet. Go away from fast food and exercise in green areas. Also, this should be for the politician and policy makers to make, more green areas and more exercise areas. And in the end, I will encourage all people to drink coffee. Black coffee is, and it is available in Africa. So these are references I use for presenting this. I would like to thank the first speaker, Mr. Professor Lazarus, because I went through all reviews and he's in all these reviews. It's difficult to present after such great speaker. Thank you.